welcome everyone to this MedVR talk. This is one of the ones I've really looked forward to. It's a one about very high fidelity simulation, which I'll mention in a minute. MedVR is a medical XR accelerator. We will open up a brick and mortar location near the Longwood Medical Area in Boston in 2023. And we'll also launch a boot camp as well to give people the opportunity and experience to work on interdisciplinary teams to build solutions for healthcare with extended reality. Today, we have a talk, mixed reality mentoring of combat casualty care related procedures in a re-perfused cadaver model. This is very interesting for a number of reasons. And when I first heard about it and then read the paper, it jumped out at me because this area of telemedicine is an area that people are really looking forward to, and going through the effort of creating this simulation applies to both the military, but also to civilian life. I was in, just before the pandemic, I was in a seminar in Stuttgart at the university where the discussion was providing remote support to emergency medical technicians. We have we have two speakers, Conrad Davis, who is a doctor, captain retired from the Medical Corps in the U.S. Navy. He's a clinical professor of medicine at Scripps Medical Group, and the section chief in pulmonary and critical care at the Medicine Scripps Memorial Hospital in La Jolla, California. We also have Matthew Tadlock, MD. He's currently a captain in the Medical Corps and a associate professor of surgery for Uniformed Services University. And he's the chair of the Joint Trauma Systems Committee on Surgical Combat and Casualty Care. We have an expert moderator. We found the talks are much better when we have a domain expert, and that is Roger Daglias Diaz. He runs the Stratus Simulation Center at Massachusetts General Brigham Hospital, and he's also the Director of Research and Innovation there, and a professor at Harvard Medical School. With that, I'll turn things over to Roger, and we can get started.
That sounds great. Thank you very much, Steve, again for the invitation. That's the second time I'm having the opportunity to moderate a panel here. So it's really great. And today I'm very excited, right? So I'm here with Dr. Davis and Dr. Tadlock to talk about the use of extended reality in military medicine. That's something that I'm very interested in. I've been involved with medical simulation training in general, medical decision support, and extended reality. And I had 2 years ago the opportunity to work with the Department of Defense in one grant to develop training for military personnel to do training in austere environment. And it was when I was introduced to the TCCC and all those great guidelines and all that knowledge that has been accumulated over the years on the military medicine. And I'm very excited to this talk today to hear from you and to learn from your experience in this project and also in your field. So thank you very much. And with that, I'll turn up to you, Dr. Davis and Dr. Tadlock, for the presentation.
Thank you so much. Matt, if you wouldn't mind advancing the slides, one, please. Okay, so the military health system provides a full spectrum of medical care to U.S. and coalition forces around the globe 24/7, 365. This includes care provided both in the U.S. as well as in operational or what we call field environments. In recent years, our trauma care in Iraq and Afghanistan was able to achieve a phenomenal survival rate of over 95% for patients who arrived at the hospital with their hearts still beating. However, due to challenging world politics, many believe that future military conflicts will be more distributed in nature, necessitating the provision of high acuity and surgical care in austere environments. Advance one, please. Austerity is generally defined by a limitation of resources and can be caused by challenges related to either insufficient capabilities, high patient volume, and or prolonged distance time required for transfer of patients to the necessary resources. While it is common for the U.S. military personnel to operate in austere environments, the concept of austerity is not unique to military medicine. Advance, please. Whether we talk about the Boston Marathon bombing in April of 2013, where we had 264 injured, sent to 27 different hospitals, the Las Vegas shooting in October of 2017, 489 wounded, sent to 6 different hospitals, or Hurricane Katrina that happened in 2005 and is the most destructive natural event to ever affect the U.S. 1,800 dead, 25,000 evacuated just to the Superdome alone, lasting weeks to months. And important to note that a large number of these patients were injury, but many were what we would call disease non-battle injury as well. So whether it be through natural or man-made disasters, the occurrence of situations that overwhelm local medical systems is becoming increasingly common in the US and around the globe. And this has become particularly apparent during the COVID-19 pandemic. Advance one, please. Even within the United States, the distribution of medical resources is not uniform. Half of counties currently lack intensive care unit beds and critical care trained physicians to manage sick patients. Yet it is not just critical care. Numerous forms of specialty care, including trauma, burn, and neurosurgical care, are also sporadically available based on geography. This shortfall has served during COVID for the catalyst of several initiatives to expand telemedicine to fill this recognized gap. Advance, please. Traditional telemedicine systems utilize some combination of synchronous, usually audio or audiovisual, and asynchronous communication to extend care to patients. These modalities may work well for many types of medical interactions and many types of patients. However, trauma, burn, and neurosurgical care often require the performance of time-sensitive, invasive, and often life-saving procedures that are less well-suited to these traditional technology modalities. This recognition was the genesis for the Artemis research program. Advance, please. Artemis is a federally funded research project that explored a high-fidelity capability that allowed a novice wearing AR goggles to interact with an expert mentor utilizing VR equipment within a mixed reality environment during the performance of time-sensitive combat casualty care procedures. Advance, please. To create this capability, we partnered with the UCSD School of Engineering. In addition to AR and VR goggles, numerous other cameras were required in both locations to capture the environment, and novel software code was written to create the immersive real-time 3D mesh in which the two individuals interacted. During the actual study, re-perfused cadavers were utilized for the procedures. In order to show this capability while also respecting the privacy of the deceased cadavers, we use mannequins in the above representations. Bottom left is a short clip showing the novice looking at the patient while the mentor views the digital patient avatar. The mentor can be seen annotating on the digital avatar, which then displays using augmented reality within the novice's field of view. The mentor uses these annotations along with real-time voice instructions to guide the performance of procedures. Bottom right, we're able to see the mentor's dashboard, as it were, showing the different tools available to them. This includes the drawing palette, allowing for holographic annotation in different colors. The mentor can also live stream different video angles within the novice's environment, as well as select or insert both still clips or pictures or other videos to instruct the novice within their field of view. The mentor can also insert their virtual hands within the novice's environment to guide them through different aspects of a procedure. Advance, please. Matt, I'll turn it over to you at this point.
Yeah, all right, thanks, Conrad. I'll talk a little bit about the study and then the paper that we presented, and then we can go on to questions, et cetera. Obviously, a lot of people were involved in making this happen, including the Bioskills Training Center at Naval Medical Center San Diego, the VMOC, and then the UCSD Department of Engineering, which did the technological piece for this. So just real brief, Conrad kind of went over this, but our general methods for the study, we had a mixed reality environment where the novices were wearing the Microsoft Hololens mixed reality smart glasses, and the mentors were wearing the HTC-Vive virtual reality headsets. The 3D mixed reality environment was created using novel software from UCSD and 3D cameras. And due to the imaging, you can see that this was an immersive environment, mixed reality environment that was shared between both the novice and the mentor. And they were really able to collaborate in real time. This was designed as a pragmatic feasibility study using Re-perfused cadavers. And then the novices were prospectively randomized either 1-to-1 to either the mixed reality mentoring or audio only mentoring. So they both groups wore the Microsoft HoloLens headsets, but one group was able to collaborate in a mixed reality environment and the other was audio only. Our novices were a mixed group of junior general surgeons and general surgery residents, non-surgeon physicians, and some special forces medics. Mentors for this study were a group of trauma critical care surgeons and neurosurgeons. And our original intent was to recruit somewhere between 60 and 80 participants. Unfortunately, we were unable to do that, which I'll get into a little bit later. So our general analysis, we first on the day of the study or the day of the mentoring of the novices, we looked at the end of it, the expert who was mentoring them then entered the room where the procedure was being performed and determined whether each procedure was performed correctly. So we did that to get an initial assessment to look at the number of procedures performed correctly. We also videotaped each session and then later had blinded expert reviewers look at those videos and then answer some questions based on a Likert questionnaire to get an idea about procedural flow, timing, and other aspects of the flow of the operation, and see the questions that we asked here. With the grant funding, we were set to start the study in 2020, and unfortunately, something called the COVID global pandemic happened. And so it was very challenging to get our planned subjects into the study. And so we really were limited to only 14 participants. You can see the groups of participants here. So we had 3 pulmonary critical care fellows, so non-surgeon physicians, 2 special forces SEAL medics, and then the remainder were either junior general surgeons or senior general surgery residents. And you can see the procedures that were performed. So the non-surgical novices did things like cricothyroidotomies, chest tubes, and then fasciotomies of lower legs. The SEAL medics did similar procedures, but we also had the SEAL medics do proximal vascular control in, above the groin and using an extraperitoneal exposure of clamping of vessels. And then the surgeons did a number of surgical and vascular procedures to include damage neurosurgical procedures as well. So these 14 novices performed a total of 69 separate procedures for the study. So there were 38 procedures in the mixed reality group and 30 in the audio only control group. And only 10 or 15% of the procedures were performed incorrectly. There was no statistical change in terms of the initial evaluation in terms of whether the procedures were performed incorrectly or not. You can see the numbers there. It was 84 versus 87%. And interesting, 100% of the neurosurgical procedures, so 5 external ventricular drain placements and then 5 damage control craniotomies, were all performed correctly in each group. Due to some technical difficulties for the video review, we were only able to review 55 of the procedures. And there was no statistical difference in procedural flow and forward planning or in completing procedures in the appropriate amount of time. And again, this was a subjective perception by those evaluating the video. We started to see a trend, though, that the mixed reality mentored novices were more likely to perform individual procedural steps correctly. And you can see the numbers here based on the Likert score. This is just showing you what was performed incorrectly by the groups. And it's really variable based on the type of novice, be it a non-surgeon physician, the medic, or the surgeon. You know, some were minor anatomic issues. So, you know, with the femoral artery exposure and shunting, the deep femoral artery was shunted, not the superficial femoral artery. Another case for one of the surgeons, as they were trying to get axillary artery exposure, had a difficult time finding that vessel and isolated a branch of the brachial plexus. And doing the fasciotomy, one of the compartments were incompletely analyzed. And you can see the rest here. And I'll talk a little bit about that a little bit more later. So, you know, I think that we were able to mixed reality mentor people in this study was, I think, pretty impressive overall. And I think, you know, unfortunately, due to some things out of our control, we had a very limited sample size. And so it was challenging for us to show a difference between mixed reality and audio only mentoring. And I think another aspect of this, I think in our study design, we underestimated the benefit of synchronous audio only mentoring as well. And I think that that's one of the reasons why we're unable to show a difference. There were some technological limitations, particularly when you're mentoring somebody who's in some kind of a hole. Sometimes the depth is hard to see, so sometimes you were unable to see what they were doing, and those things I think will improve over time. Obviously, cadavers may have variable anatomy, and then getting into the technological limitations again, that those image resolution issues were sometimes hard for us to see, you know, what the novice was doing at times, and there were occasional issues in precisions of holographic annotations, which I'll show you, and then this had a fairly large equipment footprint as well. So this is just showing you one of the limitations. So on the left is the mentor, you know, drawing on the mannequin in the mixed reality environment. But on the right, you can see what the novice is seeing. And at times, what this is showing is there's a few millimeters or maybe a centimeter or two of difference where the line is drawn virtually and what the novice is seeing. And this image kind of shows you that. You know, I think given all of our limitations and that we had to do this during the COVID pandemic, I do think that we showed that this is possible, and I think that there is a lot of future potential for future studies and future applications of this. And some of these procedures are complex, and I'll emphasize this a couple of times. This video on the right here is one of the Special Forces medics actually performing a fasciotomy while being mentored virtually in the mixed reality environment. But we're taking relative novices doing some very complex procedures and having general surgeons perform emergency neurosurgical procedures. There's a limited number of neurosurgeons in the military in general. And I think that this is a tremendous application of this technology. And I'm just emphasizing that again. I think this was a big part of this study that we were able to do this. And I'll leave this slide here open, and we'll open it up to questions from the moderator in the group. Thank you.
Thank you very much, Dr. Days. And I encourage the audience to send questions, please, through the chat or the Q&A. I'm gonna be integrating them into the discussion now. But my first question for you is really, I'm curious to know more about how did you get involved with extended reality, right? So I know you have a extensive career as military members and in medicine as clinicians. And when was the moment that you saw okay, we have a challenge here, and this type of technology could be a good fit, a good solution for this type of challenge? Can you tell us a little more about how that happened at the beginning?
Conrad, I'll let you take that, because I owe my involvement to this project a lot to you. So I'll let you go ahead and take that.
Yeah, so I think the idea really just came up because we recognized that there was a gap in capability. And again, I certainly can't claim total credit for this myself. There's a core group of several individuals within the military health system that we're all working concurrently within the telemedicine space. Colonel Jeremy Pamplin at Tatrick and Colonel Sean Hipp at the Virtual Medical Center, and myself. And so I think we were kind of discussing, this gap and trying to figure out how to solve it. And this was one of the ideas that came up. I think one of our limitations or our mistakes was trying to do too much, in the sense that, we were both kind of refitting, reformatting existing technology into a new capability, while also trying to test that at the same time. And so it really was a very large objective. I think with smaller pieces or smaller bites probably would have been better. But yeah, that's kind of how it came up. Over. Did that answer your question?
Yes, no, absolutely. And it's very interesting, right? I think to me it was very clear, it could show the feasibility of this, right? And I think that's the first step. And sometimes when you do the feasibility study, you find a lot of new challenge that I had not thought before. And yeah, I agree. It's very common to have the evaluation part of the second study after the feasibility one. But I think it was really great. I mean, in addition to showing the feasibility, and the possibility of doing this, and also I think one of the very interesting things here is using cadaveric models, right? And how was that decision, right? Because most of these studies and using extended reality use simulated models. And how was that decision? Why did you decide to use cadavers instead of these patient simulators?
I can take that a little bit. So first, in regards to your first question, I'm a technological novice, or very much a tech novice. And I had a lot of doubts about this, but going through this process from the time Conrad first, introduced me to the concept, I really see the value of these types of technologies across many spectrums, not just military medicine or combat casualty care, obviously austere critical care, mentoring novices, and then I think there's a role in teaching residents in graduate medical education in this as well, that maybe give them some better training opportunities. So I think there's a lot of applications to this kind of mentoring. To answer your question, in the military and in general surgery, so the American College of Surgeons has a course called ASSET, Advanced Surgical skills and exposures for trauma. It's a cadaveric-based course to teach surgeons vascular exposures and emergency trauma procedures to save a life. In the military health system, there's a 2-day version of that called Asset Plus that all military surgeons are required to take approximately every 2 or 3 years. And so in my experience in trauma and military education, we thought that taking these standardized courses based on a cadaver would be a perfect model. And we took some of the procedures that are in those courses and brought them into the study.
Yeah, that's very interesting. There is one question here also specific about the perfused cadaver. Did you measure blood loss in the perfused cadaver as a measure of outcome?
No, we did not. And that would, I have a lot of experience over the years in different places with perfused cadaver models. We did not measure blood loss. I think that would be hard to do, but it does make the procedure more realistic for the novice going through it if the vessels are bleeding. But we did not measure blood loss, and I think that would be hard to do with because these are fresh cadavers. There's other fluids everywhere. I think it would be hard to measure that. Yeah, no, absolutely. So I have another question here from Lulu, and I think it's related to build on your mention about training, right? So the question is it more important to train surgeons while in the middle of surgery or before, after? And maybe you can expand a little more about how that happens in military medicine, right? Like pre-deployment training, just-in-time training, and then maybe some remediation training. How does that happen? How extended reality could be used? I have a lot of opinions on that. If Conrad, if you're okay, if I'll take that one. So I think it's multifactorial, because I think, when we deploy in the military as a surgical team, when we're not doing anything and we're bored, that's a good thing, because that means the people we're there to take care of aren't getting hurt. And so that is a constant problem. And so I think there's two aspects. I think, if you're on a surgical team, no matter what your role is, I think you need to be doing actual clinical care before your deployment. I think that the role for just-in-time training is primarily, it shouldn't be clinical experience in trauma, burn, or critical care. But what is important for just-in-time training, I think, is how to work together on whatever platform you are, and getting those team dynamics together, those team communication skills. And I think that's the most important role for just-in-time training. I think if you're in a scenario which is, like I said, a good thing, and you're deployed for 6 to 9 months and you're not doing a lot, I do think that intermittent training during that deployment to work through your processes, how patients are going to be moved, how you're going to communicate, I think that is very important during a deployment. And I also think that there could be a role for mixed reality, for a number of either virtual reality or mixed reality, into doing some refresher training on a deployment. Hopefully that answers your question.
And perhaps just to add on to that, in the military, but also probably in civilian life as well, especially if you're not in a high volume, high acuity level 1 trauma center, there's going to be procedures or skills that you are trained to do, but you don't do real often. And it may be a procedure you only do once a year, or even less. In the military, you may deploy on an aircraft carrier or in a remote environment where you're not doing invasive procedures or surgeries regularly, but you still need to know how to do them when called to do that. And historically, we would, open a textbook or look at a video or do something along those lines to kind of prep ourselves before we, step into the ICU, the OR, the procedure suite. Wouldn't it be great if we could watch a 3-dimensional video, not just a 2-dimensional video, but a virtual reality video of the said procedure, so that we can actually see anatomic relationships in depth and see how the procedure or the surgery unfolds, and what we should be doing and watching out for. So that was kind of another thing that came up as a aha moment during, I think, Artemis, was that I think that is possible technically. Certainly not the point of our study, but that would be something that could be an offshoot and certainly would make sense.
Yeah, Absolutely. So I have another question here from Jessica. Such a solid solution to the gaps in access capability question. What is the decision process to assess in real time in the field when this XR mixed reality would be implemented? And maybe here I will ask you to differentiate the purpose of what to develop and maybe the different purpose that it could be. Like one is like training, right? Not during like real patient care, and could be like before or just in time or refresh training, but also for real time decision support and procedural guidance support during real patient care, right? What was like the original purpose of this, or maybe both? Could you speak a little more about that?
Yeah, I think that in the future it'd be ideal if this was a capability that you could have, and it could be at different roles of care. And just for the group, we often talk about capabilities of care in the military as either being role 1, so that tends to be point of injury, and these are NATO definitions. Role 2 tends to be an austere surgical capability. Role 3 tends to be an in-theater hospital with more advanced trauma, neurosurgical, and critical care capability. And then role 4 might be either a real hospital in the continental United States, or like Landstuhl, Germany is a role 4, a NATO role 4 hospital. And so I think there's applications at all roles of care, to be quite frank with you, for this type of technology. So if you're a medic in a role 1 environment, be it in the field or whatever, and you have a mission set where should you get casualties, you can't move them on for several hours to days. I think that this should be a planned sort of for you to talk back and get help to a physician and or nursing to help you in the care of that patient. And I think it should be, we actually in the military, we train to some extent to provide virtual health support to providers. Most of it's kind of asynchronous over the phone or using pictures, but we train to that right now. And I think once this becomes a real capability, we should train to that. And so if you're going to be in a prolonged situation at any role of care, I think that this should be a technology that we could get to the point where we use. Similar in a role 2 setting. So if you look at the last 20 years of war in Iraq and Afghanistan and the Middle East, if you were injured, you were rapidly moved on from a role 1, so point of injury, to a role 2 surgical capability, operated on, and then sent to that in-theater hospital. And sometimes the sickest patients within 72 hours were in Landstuhl, Germany. I think if you think about future conflicts, that may not be possible with a peer-peer sort of fight. And so we're going to have to, like, these role 2 or austere surgical teams are going to have to take care of patients in that austere environment for days. And I think there's just a lot of stuff they don't do a lot of critical care. They do some, making points where maybe a trauma surgeon is the expert and taking care of these kind of injured patients through the long term, or even disease non-battle injury. If you're in a certain environment where there's certain endemic infectious diseases, whatnot, and you have sick patients, boy, wouldn't it be great to go back and get that expert help real time? So I think it depends on the environment, but I think it should be something planned and practiced to answer the question. And the only other thing I'll say is, I think even now, we have, and Conrad can speak to this too, we have a number of military medicine, a number of hospitals around the world that have limited medical capability, but sometimes they get sick patients either in the ICU or wherever. And I think right now there's an application for this type of stuff. If a surgeon maybe has to deal with something that they're not used to having done for some time. And so our forward deployed hospitals in different countries benefit from this type of technology now in terms of critical care, but I think you could expand it into operating rooms and elsewhere.
And I would also add to that there are numerous hospitals in rural parts of the United States, CONUS America, that also have limited capabilities and typically will transfer patients sometimes several hours to find an appropriate surgeon or surgical care for that patient, which historically has been okay, but during the COVID pandemic, receiving hospitals haven't been able to accept patients, or procedures sometimes were time sensitive, and this led to bad outcomes. So I mean, there's also applications, I think, here at home, not just abroad for the military.
Yeah, and to expand on that, there's over the last 10 or 15 years, there's a study out of Israel looking at head injury patients and the ability of neurosurgeons to at least read the CT scans, and then they can help the person on the ground make a decision in that rural environment, whether or not to send the patient on to a higher level of care or not. So it'll help triage resources. And in the burn community, there's been a lot of great applications in terms of having at least video teleconferencing capability to help the person on the ground estimate the size of the burn, the depth of the burn, and really help them with the initial resuscitation, and determine if it's necessary to take the risk to fly that burn patient from a rural environment to a burn center, because that has its own inherent risks, and it really helps with triage and resources as well.
Yeah, no, that's very interesting. Also, there is a study here by Dr. Lee Shawn from the Mass Chan for telestroke, right? And during the pandemic, right? So the concept of like, you're like in the, not necessarily rural, right? Because not all hospitals have like a stroke team and neurologist there. And they did this like telemedicine, not VR, not XR, just regular teleconferencing. And they measure like outcome, satisfaction of the EM team, and the cost, right, of that. So the cost effective was really, really huge, with the same quality, the same satisfaction from the clinicians, receiving a tele-orientation from a neurologist instead of having a neurologist in place in every emergency department, right? So there are many areas. And the other thing I'd like to add is, because it's very interesting, I had the opportunity to have a few grants from NASA, and it's very similar challenge, right? When you talk about like long duration missions. And one, of course, is the duration, the austere environment, and low resource. And we actually developed like something similar called AR coach to guide astronauts during long duration missions. But for them, and I think in your area also may have those situations, and I saw a few questions here where communication, any type of communication is interrupted, right? It could be internet communication or satellite communication. And one of the things we were designing for that challenge would be like an offline mode using artificial intelligence that could guide you without a real-time guidance, but a built-in capability to guide you through like different algorithms, right? A different medical algorithm or triage that can help you with that. To be like autonomous system, could also be embedded into this system.
Yeah, we actually have a paper published in Health Affairs a couple years back, I think 2019, that kind of talks about that. But that is the end state. That is the goal. Certainly in the military, we're very familiar with communications constrained or even communications absent environments. And so telemedicine isn't always an option for a variety of reasons. So eventually what we would like to get to is a fully autonomous medical assistant or medical system. And there certainly are R&D lines of effort, mostly through TATRIC in the U.S. Army, that are focusing on that. But I think many believe that that's going to take several steps. We're not quite there yet, and that perhaps, a high definition mixed reality support is kind of a first step, and that eventually maybe that'll lead to, through advances in artificial intelligence, machine vision, computer learning, through a functional AI. For that scenario.
Yeah. Oh, absolutely. Now, I have a question here that I've been saving this question towards the end, and I just saw that Jessica asked the same question. So she's saying that I've been implementing VR in the medical space for years. There are many use cases and applications, but much hesitation to adoption among healthcare providers, right? And my question is this, and I've been doing I have the opportunity to have like this research lab focused on usability and human factors of like different digital health technologies, right? In terrestrial, regular, traditional medicine, let's say, non-military and space. And adoption by clinician, it's really a huge concern. Most of them driven by new technology that doesn't integrate with their clinical workflow, and many times cause more disruption and sometimes even cognitive overload, because now you have a secondary task. It's a new device or new system, right? Yep. In addition to the regular one. And I think in your case, I'm very curious because it's not only integration with the clinical workflow, but with the operational, the military operational workflow, right? So how do you see this technology being integrated into this like clinical workflow, but also the operations that's completely different from having patient care in the hospital?
You want me to start, Matt, or do you want to?
Yeah, go ahead and start, and then I can add on. I have a couple thoughts. But
So I think that was one of the things that I learned through the study that I perhaps ahead of time didn't fully appreciate, was how much work goes in to kind of configuring or making sure that a solution fits within a clinical workflow. The IT team continually came back again and again and was asking question after question. And sometimes I think the questions seemed obvious to the clinicians in the group, the physicians, but you know, they don't have the same background and they didn't understand or didn't know. So I think it's absolutely critical that any new technology that's created partners with whether it be health informatics or even better, practicing clinicians, surgeons, physicians that are doing the actual patient care in order to optimize usage and collaboration. You can't just throw something extra within medicine that people will refuse it. Absolutely true.
Yeah, a couple thoughts. I think, you know, it required, just for this project to be a mentor, required some training and experience with the technology in of itself, particularly for me as a technological novice. But to your broader question, and how do we get clinicians to be okay with this? I think one of the good things about the COVID pandemic is that the applications of virtual medicine, people see their value. And I think there's some bad things about that, because I know of some patients who maybe have been seen virtually and some things were missed, but I think if done correctly, the COVID pandemic has shown us the value of various forms of virtual medicine. So I think you have to crawl, walk, run. I think we need to use more of it. So just something simple as a post-surgical follow-up. There's some studies out there of using, you know, phone-based app sort of technology, so you can look at a surgical wound and then talk to that patient, and they don't have to drive an hour and a half to your doctor's office to see you in person. So those studies are out there. That's happening now. It's happening different places. I think that's, so I think we need to show the value to our providers on basic technologies that are real now. Obviously with tele-critical care, that is in various areas. I do think, you know, in areas where trauma centers take on rural patients, I think we can, as a system, there's little pockets that do this well, but there's a number of trauma patients that I take from a rural, you know, emergency room that's 2 hours away, that aren't sick and that don't need to be transferred. And if we had a system where I could evaluate them just via video teleconferencing, look at the imaging, look at the vital signs, I don't think you need to move that patient, particularly if there was a system where they could be rounded on. So something simple, blunt chest trauma, they're okay, CT scans are fine, but need a chest tube. You could, if you had the right provider at the other end, you could help them manage that virtually. And so I think we've already seen the value in some studies in burns and in neurosurgical emergencies. I think we need to keep showing the value with the technology that we have now. And then the other aspect, I think, in terms of virtual medicine, I think there's some aspects, like I said, in graduate medical education. Because, you know, if you're a resident and you're doing a procedure with your attending there with you, there's some things that you're not going to learn because you have that help there. But what if that attending was virtually mentoring you, say initially on a cadaver based? What skills, how much more advanced is your skill set going to be when you're there by yourself, but with a virtual mentor? And I think that's really want to explore as well. So, and as you keep using this technology to our providers and they see the value, and particularly taking care of sick patients, you know, I think we'll get to the point where it's adoptable, but I think it's a crawl, walk, run kind of thing.
Yeah, no, absolutely. Thank you very much. There are a few questions here about asking about the stage of development of the system, right? If it's possible to do a demo, if it's FDA approved, and already answered that, Conrad. But could you speak a little about what is now the stage of this project? What would be like the next step for this project to go from like feasibility to showing effectiveness, and maybe even the future being implemented in the military?
Do you want me to take that, Conrad, or?
You can start. I'll chime in after.
All right. Well, so we for this project specifically, we went with a new group to sort of develop the technology, and we have it ready, but there's been a lot of changes in the military, and so still have to work on funding for the next step. Okay, so I don't have that definitively out there. There's a lot, as people know, there's a lot of changes going on in military medicine in terms of structure and leadership structure. So I won't go too much into that. What I would like to do, I think what I personally would like to do would focus on sort of three general aspects of this type of technology. First of all, taking general surgeons who are in remote, either rural or deployed environments, where they have to perform surgical procedures that they don't normally do in their regular practice, and getting at them being virtually mentored by the specialist. So what am I talking about? Obviously, emergency neurosurgical procedures. So you take somebody who's got surgical skills, but they may need some coaching. Maybe emergency urologic procedures, such as like a testicular torsion, or laparoscopic ectopic pregnancy surgeries. So in a surgical emergency. So I think that there's some real practical applications that I would like to get to. And I think also, as you look at role one providers, so medics, independent duty corpsmen in the military, what is the role of this kind of mixed reality mentoring, just not even in surgical procedures, but in the care of critically ill patients? Maybe you have somebody with a shoulder dislocation, and they're in an austere environment, and they're not sure how to reduce that shoulder. But if you can either have an asynchronous thing that they can watch virtually, or mentorship. So I think there's a lot of applications beyond procedures, and we need to do studies that target each of those populations.
Yeah, well, that's really great. Go ahead, Conrad.
I was just going to say, when we did this study initially, I was still active duty. I have since retired from the military. So I am certainly interested in doing more work in this space. But again, funding is the issue, finding a funding source and partners for the study. But
Absolutely. Yeah. And I have another question, and I'll just send the link here. We know from like the public that there's like the Department of State has like this project called IVAS, right? Integrated Visual Augmentation System. It's basically a modified HoloLens, right?
Yes.
But my understanding is that primarily this is designed for like operational tests.
Yeah, so I can comment on that a little bit.
Do you see a future where these medical capabilities will be integrated into that system?
Potentially. So yes, IVAS is a contract that was awarded by the U.S. Army to Microsoft a couple years back, essentially to expedite the development and deployment of a version 3 HoloLens for the military with specific requirements. It has to be ruggedized for, moisture and dust and vibration and so forth. It has to be encrypted, but it's going to basically replace their current visual augmentation systems. So it's a multi-year contract. It will field or should field a military-approved encrypted version of the HoloLens that will, IVAS is mostly talking about displaying, maps, friend, foe, communications, logistics, things like that. But boy, wouldn't it be great if we could use it also for procedural telementorship. So yes, I think that has been discussed. I don't have any privy into those conversations at this point, but IVAS should roll out here in the next couple years, and that is a possibility.
Well, that's really great. So I have a last question here. We have like 5 minutes, and in our audience, right, we have a lot of like clinicians and VR, XR experts and project managers and enthusiasts, but we also have a lot of developers. So the people who are like the engineers and the developers behind these systems. And you had the opportunity, right, as like subject matter expert to interact with developers and IT people, right? So, and sometimes in development, we see it's very difficult to fill this gap and have like, because we come from different backgrounds, right? And the way you see the world is very different. So what advice would you give for like people, developers in the XR world, when they are working with clinicians and like military experts? What are the advice you give to them to ask and to incorporate subject matter expert advice into the design of the system since the early stages?
That to absolutely do it. I think that is the risk and the pitfall of some great medical technology, is that it's developed and implemented really without sufficient input or collaboration by practicing clinicians. And nothing against people who have an MD behind the name that don't practice, but if you don't know the workflow and know what the flow of care is in a hospital setting, and not just in general, but down to the minutia. So like, for example, I don't necessarily know the workflow for Dr. Tadlock, right? Because he's a surgeon and I'm an intensivist. You really have to know the specific workflow of the environment that you're attempting to implement a technology solution to optimize it. Otherwise, you're going to end up with something that is just labor intensive and they don't want to use it. So yeah, and to expect there to be more questions than what you think, and to anticipate or plan on it taking more time to have these discussions and do these walkthroughs than you might think otherwise.
Yeah, I just echo and say early and often, and it needs to be people who routinely are doing the procedure or whatever it is that you're trying to develop the work for or the technology for.
Absolutely. Yeah, no, that's a great lesson as well that I learned. My lab is really to involving at the early stage, brainstorming stage, right? Because many times we spend like 6 months, 9 months developing something that no one wants to use for many reasons, right? So we really approach this like doing like we call cognitive task analysis with clinicians to understand what they do every day, the decisions they make, and then we design whatever software, really integrate that at the early stage. So it's a really great lesson. Okay, so thank you very much. I learned a lot from this talk today, and I'm going to turn it over again to Steve for wrapping up.
Yeah, let me just wrap things up by saying thank you to Conrad Matthew for this talk. Very, very valuable. I think it'll be a curriculum for many people in the coming years. And thank you, Roger, for your domain expertise in bringing out the best in this talk. I really enjoyed it. I will when we post the talk on our website so that you can review it again. I'll also connect the papers that they published that I think will be very, very useful. And you can both read the details as well as review this this talk. Last but not least, we have a talk coming up next month on January 11th after the holidays. It's from the Veterans Administration. Which is an interesting story where they've gone from 1 to 160 VR user research sites. And the two people that will be talking, Ann Lord Bailey and Caitlin Rollins, one is really focused on the infrastructure of the deployments, and the other is focused on on how, and Caitlin Rollins is focused on how this fits into the continuum of care. And we have NIH's lead, who is funding all the grants in extended reality as the expert moderator. So it'll be a great session. So with that, I thank our speakers and our moderator and the folks who attended, and look forward to further discussions on this. Thank you.